So, do you feel like you constantly need to run to the bathroom, even when you literally just went, completely ruining your sleep? Or maybe there's this persistent aching pain in your pelvic area that leaves you secretly terrified at something really serious, like cancer. If you've been told your tests are completely normal, but you are still in daily pain, you know what? You aren't imagining things. It's incredibly frustrating to know something is wrong with your body, only to have standard tests tell you you're perfectly fine. Today, we are taking a close look at a condition that affects millions of people, often in total silence.
All right, let's dive right in. To figure out what's going on, we have to look at how this condition is different from what most people naturally assume they have, a UTI. Interstitial cystitis, or IC, is a chronic bladder condition that causes ongoing pelvic pain, pressure, and severe urinary urgency. But unlike a typical urinary tract infection, which is caused by bacteria and clears up pretty easily with medication, IC stems from chronic inflammation of the bladder lining and heightened nerve sensitivity. So the really crucial point here is this. Because IC is not an infection, antibiotics are not the standard treatment. They simply won't work to fix the underlying issue.
Welcome to today's Explainer, where our main goal is to finally solve the frustrating mystery of interstitial cystitis. We're going to break down exactly why your bladder hurts, untangle the complex mechanics of the condition, and map out a clear, evidence-based path to mastering your symptoms so you can reclaim your quality of life.
Here is our roadmap for today. First, the invisible illness. Second, what is interstitial cystitis? Third, the 3 IC subtypes. Fourth, triggers and IC flares. And finally, multimodal treatment and relief.
Okay, starting with Section 1, the invisible illness. You know, it can surprisingly take patients years to finally get this diagnosis, and it's because of this exact process. IC is primarily what we call a diagnosis of exclusion. This basically means your doctor has to prove what it isn't before they can definitively say what it is. They're looking for a 6-week history of urinary frequency, urgency, and pain, usually pain that gets worse as the bladder fills and gets better when you pee. But while they're documenting all of that, they actively have to rule out other anatomical issues. They'll check for UTIs, yeast infections, bladder stones, and even tumors. If all those standard tests come back perfectly normal, they might move to specialized tests for complex cases. Things like a cystoscopy or hydrodistension under anesthesia, just to inspect the bladder wall for specific pinpoint hemorrhages called Hunner's lesions. Moving on to Section 2, what exactly is interstitial cystitis? Think of your bladder as a storage tank that has this natural, built-in protective barrier called the GAG layer. This slick, mucus-like substance is essentially like the non-stick coating on a frying pan. When that coating gets scratched up or wears thin, everything you cook starts to stick and burn. In IC, this protective lining loses its barrier function. That allows the normal acidic chemicals in your urine to seep through and severely irritate the underlying bladder wall and nerves. Essentially, your bladder tissues become highly sensitive to the heat of your own urine, which causes that intense, burning pain. Now, for Section 3, the 3 IC subtypes. It turns out IC is definitely not a one-size-fits-all disease. The American Urological Association now recognizes 3 distinct subtypes, which completely changes how we approach treatment. First up, we have the bladder-centric subtype. This is where patients have clear bladder wall dysfunction, like those Hunner's lesions we mentioned, and they tend to respond really well to localized bladder treatments. Second is the pelvic floor subtype, which is all about tight, sensitive, and spastic pelvic floor muscles. And third, the chronic overlapping pain subtype. These patients experience widespread pain conditions way beyond just the bladder, like IBS or fibromyalgia. It suggests their central nervous system is stuck in a constant fight or flight mode, requiring a much more systemic mind-body approach to treatment.
And this brings us to exactly how that pelvic floor subtype operates. When you have tight, knotted muscles, called myofascial trigger points, in your pelvic floor, they're constantly firing off chronic pain signals right up to your spinal cord. And here's where it gets crazy. This painful input can trigger an antidromic reflex. Basically, your spinal cord gets confused and mistakenly misfires signals back down into the bladder's nerves. That releases inflammatory stuff like substance P, which causes mast cells to degranulate, and boom, you've got visible inflammation and severe bladder pain. The entire painful loop started with just tight muscles. It's a fascinating, but obviously very painful, central sensitization loop.
Let's look at Section 4, triggers and IC flares. Diet plays a massive role here. If your bladder lining is compromised, pouring highly acidic food and drinks into it is just a recipe for a disaster.
Patient experts often put it like this. Would you pour hot coffee on an open wound on your hand? No way, right? So you have to be really mindful of what you're putting into your body. Highly irritating foods include your coffee, tea, citrus fruits, tomatoes, spicy foods, and artificial sweeteners. On the flip side, you want to stick to bladder-friendly, low-acid options. We're talking plain water, blueberries, pears, poultry, rice, and oats. Literally, just by swapping out your morning coffee for a glass of water, you can immediately start reducing the acidity of your urine.
Here's the catch, though. Modifying your diet requires genuine patience. Giving up your favorite foods for just a few days or a week, that won't cut it. You really need to give your bladder 3 to 6 months of a strict, bladder-friendly diet to allow that inflammation to fully calm down and let the protective lining actually begin to heal. It's absolutely a marathon, not a sprint. Finally, Section 5, multimodal treatment and finding relief. A lot of patients naturally start by looking for relief over the counter. In fact, surveys of the IC community show that over 85% of respondents are highly willing to try over-the-counter supplements to help manage their symptoms. That is a massive chunk of the community. When we look at the data, the top supplements patients are turning to are aloe vera, pre-leaf, and D-mannose. And the response is actually super encouraging. Almost 60% of users report experiencing some real degree of efficacy, whether they're using them for chronic daily management or just to help control those sudden, painful flare-ups. But, supplements are just one piece of the puzzle. The most effective first-line interventions really focus on behavioral and physical therapies. This includes bladder training to gradually increase the time between your bathroom visits, stress management to help calm that central nervous system, and of course the dietary changes we talked about. But honestly, perhaps the most crucial intervention for a lot of people is pelvic floor physical therapy. If you fall into that pelvic floor subtype, physical therapy is absolutely vital to restore normal muscle tone and manually release those agonizing trigger points. Let's look at the actual physical proof here. The electromyography, or EMG data, paints such a clear picture. Those high, erratic spikes you see, that indicates severe resting muscle tension, meaning the muscles are basically just constantly clenched. But after targeted manual myofascial release, look at that. The tension dramatically drops to a flat, calm baseline. And the clinical data backs this up entirely. As that muscle tension drops, patients report significant decreases in their urgency, frequency, and overall pain scores. It's a real game changer. Now, if first-line therapies aren't quite cutting it, don't worry. Your urologist has a really deep bench of secondary options. Oral medications like Almiron can help repair the bladder lining, while antihistamines can reduce mast cell activation. There are also intravesical installations, where medications like DMSO or heparin are placed directly into the bladder via a small catheter to just coat and soothe that irritated lining. And for severe treatment-resistant cases, advanced therapies like sacral neuromodulation devices or even Botox injections into the bladder muscle can be highly effective at interrupting the nerve signals that are causing all that pain. Now, while we're talking treatments, it is absolutely crucial to know what not to do. The AUA guidelines are super firm on this. Long-term oral antibiotics and high-pressure, long-duration hydrodistension should not be offered. Period. Remember, this isn't a bacterial infection, so antibiotics are literally useless here. And that high-pressure bladder stretching? It carries a huge, unacceptable risk of bladder rupture and tissue necrosis. The risks just totally outweigh any potential benefits, so definitely steer clear of those. So what does this all mean for you? The biggest takeaway is that living with interstitial cystitis does not mean you have to suffer in silence indefinitely. Even if your tests were perfectly normal, your pain is real, and the science to treat it is advancing rapidly. So are you ready to stop constantly scanning every room you enter for the nearest restroom? I really encourage you to use this information to go consult a specialized urologist. Take that first step toward creating a personalized, multimodal care plan and reclaim that vibrant quality of life you deserve. Because if your pain was never just a simple infection, what else about your body's healing potential is just waiting to be unlocked?